All right, so John, should we get started? What do you think?
All right, good morning, everyone. Welcome to Neuro-Ophthalmology Rounds. I'd like to welcome Dr. Jonathan Michelli, who is one of our newer consultant neuro-ophthalmologists, and he actually went to U of T, where he did something that sounds actually kind of difficult than the regular undergrad. He did laboratory medicine pathobiology before attending medical school at McGill, returning to do residency with us, where he was the winner of the Boywoodka Cup for the highest academic standing. And he went down to Atlanta, Georgia, where he did his neuro-ophthalmology fellowship with doctors Nancy Newman and Valerie Buse. He is the author of many papers, and he's already written a book on neuro-ophthalmology as well. Very impressive, Jonathan. But more impressive is that he is also the team ophthalmologist for Toronto FC. So now I know where to go to get my tickets, since they're impossible to come by. So welcome, Jonathan, and also to you, Jason, one of our PGY4 residents. Good morning.
Thank you, Dr. Lloyd. So I guess I'll get started with my case first. The title of our presentation is An Unwanted Problem. I'm Jason, one of the PGY4s. Special thanks to both Cabri as well as Dr. Michelli for helping and getting this presentation together. This is the QR code if you guys want to sign up for the attendance. Just take a quick snap of this QR code and then we'll go on. So the case starts off as a 28-year-old female that was who was referred for bilateral optic disc edema. She came to clinic, or she initially came to her initial provider because she had endorsed blurry vision for the last 3 days. Otherwise, she was actually healthy with no medical conditions, no allergies, or any family history of any type of vision loss. On further history, when she came to clinic, she actually underwent an elective medical abortion 2 months prior to coming to clinic. This occurred early in her first trimester. It was a medical abortion, so she took mifepristone misoprostol at that time, and since taking that medication, she had endorsed constant menstrual bleeding with a hemoglobin of 128. Subsequently, a second dose of mifepristone misoprostol was administered 1 month prior to her presenting, and she continued to have a constant menstrual bleeding at that time, and she subsequently underwent a dilation and evacuation 2 weeks prior to presenting to neuro-ophthalmology clinic, and the menstrual bleeding had stopped at that time. Now, so then just to summarize, so 2 months before she came to blurry vision, she had the elective medical abortion. 1 month afterwards, she then had a second dose of the medication. And then now 1 week prior to coming to clinic, she developed headaches, neck pain, as well as pulsatile tinnitus, which again are symptoms consistent with elevated intracranial pressure. And then 3 days prior to presenting to clinic, she had the blurry vision in her right eye. And I think it's important to note that her BMI, when we elicited on history as well as on examination, was 24.5 kilograms per meter squared. Okay, so a bit of a long-winded history, but we'll summarize that again later on. On examination, you can see that, apart from the fact that her vision is slightly worse in the right eye at 20/30, everything else was pretty much normal with a normal slit lamp exam and normal pupillary exam with no relative afferent pupillary defect. And on fundus examination, as you can see here, there is bilateral optic disc edema with some peripapillar hemorrhages and cotton wool spots. And there's also some venous dilation that you can see, as well as some retinal striae or retinal changes here. And we're going to chat a little bit more about that, particularly in the right eye near the fovea. And we're going to chat a little bit more about that. So given that the vision is worse in the right eye, what tests would you order to evaluate the cause? So unfortunately, a lot of our residents can't actually pipe in and answer the question. So I'm going to rely on them to answer this via chat. What would you do? So I'll give about 10 more seconds.
You've already got 3 votes for OCT.
3 votes for OCT. Perfect. So yes, so the answer is an OCT macula of the right eye. And I think, given of all the investigations that are ordered here, it's the most easily accessible, and it's a quick and easy test that you can get in clinic. And it's also particularly relevant in this case because you can see here in the right OCT that there is a collection of subretinal fluid involving the fovea with the loss of foveal contour. And if you actually look carefully at the fundus photograph 2 slides prior, you can see this presence of subretinal fluid with some wrinkling or with some wrinkling adjacent to the fluid, indicating that it is true subretinal fluid when you do look at it on slit lamp examination. And on visual fields, you can see here there are enlarged blind spots as well. So what should we do next? And this is a question that I'll answer myself. Given that this patient has had lots of menstrual bleeding in her history, I think it was worthwhile to get a CBC and coag studies. And given the fact that she has, symptoms and clinical features suspicious of elevated intracranial pressure, I think it's paramount to order an MRI, MRV of the head, as well as a lumbar puncture to further investigate this. So the CBC, surprisingly showed a microcytic anemia with a low MCV as well as a very low hemoglobin with low total irons, consistent with a diagnosis of severe iron deficiency anemia. And the MRI, MRV essentially showed no mass. There was no evidence of cerebral venous sinus thrombosis, but there were some findings suggestive of intracranial hypertension. The blue arrows there point towards this, the focal stenosis at the junction between the transverse and sigmoid sinus junctions. And the lumbar puncture had demonstrated an opening pressure of an elevated opening pressure with normal CSF contents. So again, a lot of things happening, but just to summarize everything, just to put everything together, this is a 28-year-old female with a normal BMI and anemia secondary to menstrual bleeding from a recent medical abortion in the first trimester, presenting with signs of intracranial hypertension as evidenced by the many findings that I've illustrated in the previous slide. So what is the diagnosis? Well, given the fact that her intracranial hypertension occurred secondary or in the context of severe iron deficiency anemia, that was the presumptive diagnosis at that point in time. So before going on further in this case, I think there are many valuable learning points from this case thus far. So let's explore that a little bit. So 2 points for discussion. So what is the relationship of anemia to IIH? And secondly, what are the retinal manifestations of IIH, which I believe that this case actually touches upon. So let's talk about the relationship between anemia and IIH. So as many of you guys know, IIH is a disease typically of unknown origin, seen primarily in young obese women. But what you may not know is that anemia is thought to be a risk factor for IIH. And the prevalence of anemia in this population is about 14% in the literature. The relationship between anemia and IIH remains quite controversial because iron deficiency anemia is actually very common or quite common in young women. However, there is a growing body of case reports and series linking the anemia directly to development of intracranial hypertension. And, Dr. Michelli and Cabri, one of our medical students, are actually currently undergoing are currently conducting an ongoing study and a review looking at papers around this very topic. And they've identified in total 53 cases of patients who developed intracranial hypertension secondary to anemia. And I think the most important points from this slide is that only 12 patients were obese. A majority of patients were actually of normal body weight and body habitus. And the most common causes of anemia in this in the population causing intracranial hypertension was iron deficiency anemia. Now, in terms of treatment, the most common treatment, surprisingly, I found very surprising in the management of IH in the setting of anemia was actually the treatment of the anemia itself in the form of iron replacement and blood transfusion. And you can see that only a small subset of patients actually were treated with Diamox and surgical interventions to lower the ICP. Only 18 patients required this. But the great part or the interesting thing about all this is of the 43 patients that were followed in the study, all patients experienced resolution or improvement of the IIH. So only a small subset of patients required, Diamox and then, a VP shunt, but a majority of patients actually responded well to the therapy for anemia. So just to reiterate, as you can see from the previous slide, Diamox and surgical interventions was only used in a small proportion of cases, and the treatment of the underlying anemia was the main intervention. And in fact, in some cases, treatment of the IIH was not successful with traditional therapy for IIH and was only responsive and only improved after the direct treatment of the anemia itself. And there are multiple reports in the literature demonstrating successful treatment of intracranial hypertension with the management of the anemia, which suggests a direct relationship between anemia and intracranial hypertension. So there are many proposed mechanisms for why this possibly could happen. I think the more, like, the ones that make the most sense are the following. In anemia, there's decreased hemoglobin levels, and it's thought that this may increase cerebral blood volume, resulting in intracranial hypertension. And in the context of iron deficiency anemia, it's thought that iron deficiency anemia can increase viscosity and can increase venous pressure from that perspective. So what should I take home from this? That's a lot of slides, it's a lot of information. What's the thing that I should take home from this? Well, I think that, given this case and given sort of all the cases in the literature, I think a CBC should be obtained in all patients with intracranial hypertension because it's an easy test to get. It's very cheap. And especially you should get this test in patients who do not have the typical risk factors for IIH, and also patients who do not respond to traditional therapy. So that's topic number one. Let's talk about topic number two, which is the retinal manifestations of IIH. Because this is, again, prior to this case, this was something that I was completely unaware of, even though I've seen, quite a number of patients with IIH in my residency so far. So Dr. Michelli and Prem, one of our medical students, actually conducted a review on this very topic, which consisted of a case series of 142 consecutive IA patients in Dr. Michelli's clinic, as well as a systematic review of 182 patients with IIH. And I'm going to sort of summarize the main points that I want you guys to take home with. Now, unfortunately, again, our residents, our brilliant residents can't actually pipe up given the format of Zoom. So I'm going to actually answer this question. The initial question I was going to ask is, can anyone label sort of the abnormal features in these photos, which comprise of, sequential patients with idiopathic intracranial hypertension? So I'll name it. So A shows a choroidal neovascular membrane. B shows subretinal fluid. C shows choroidal folds. D shows retinal folds. E, from the dilated veins and tortuosity, shows venous stasis retinopathy. And F, with those yellow flecks around the fovea and the macula, shows macular exudates. So these are the retinal manifestations of IIH. I'm going to talk a little bit about each of them. So as to why venous stasis retinopathy happens, it's related to poor venous outflow at a severely crowded optic nerve head. As to why chorioretinal folds occur, it's due to transmission of high ICP behind the globe, essentially resulting in flattening the globe and wrinkling of the retina, the choroid, and the various structures in the posterior part. As to why choroidal neovascular membranes occur, the pathophysiology is thought to be related to axoplasmic flow stasis, choroidal hypoxia, and secondary angiogenesis. Subretinal fluid is thought to be contiguous to the spread of optic disc edema and tended to result in long-lasting disruption of the ellipsoid zone. And lastly, macular exudates can occur in IIH as a result of capillary leakage and tended to happen in the setting of severe hypertension in the patients that were studied in the review. This is, of the retinal manifestations listed in the previous slide, CNVMs and subretinal fluid can lead to paracentral visual field defects highlighted in this visual field. And it's important to know this because it's important to distinguish visual field defects caused by these retinal manifestations from optic nerve dysfunction, because that has, visual optic nerve dysfunction, seeing early signs of that is an indication for earlier intervention. Thus, it's important to perform OCT maculas in patients in IIH, as most cases of subretinal fluid were difficult to detect clinically with slit lamp. And this imaging modality is also helpful in explaining central visual field defects or reduced vision that may be inappropriately attributed to optic nerve dysfunction. Again. And this is, an OCT demonstrating subretinal fluid secondary to papilledema. And you can see that when the subretinal fluid resorbs, there was subsequent disruption of the outer retina and the ellipsoid zone, as you can see in the blue arrows in part B, in picture B. And this is sort of a plug for the website that Dr. Michelli, myself, and various faculty member at the University of Toronto have been working on. We actually have a neuro-ophthalmology section on our website now, octcases.com, where we actually have a case that demonstrates all the, a majority of the retinal manifestations of idiopathic intracranial hypertension. So if you do want to take a little bit of a more in-depth look and through various questions, I highly encourage you to check this website out. So what should I take home from this? So the main take-home message is to be cognizant of the retinal manifestations of IIH and to be aware that some retinal manifestations may cause visual field defects that you may mistakenly think is due to optic nerve dysfunction. And this is important to distinguish as the visual function has a significant impact on the urgency for treatment. And it's also important to recognize that CNVMs can be caused by idiopathic intracranial hypertension, as treatment of IIH obviously would not improve the visual loss from a CNVM. Rather, it's through anti-VEGF medications that CNVMs can be treated in the context of IIH. So lastly, I hope that these findings encourages you to get an OCT macula on a majority of your cases of IIH, particularly the more severe ones with abnormal visual field findings. So, that was a bit of a detour, but I hope, those are the two main learning points that I'm hoping to convey to you from this case. So back to the case. So just to summarize again, a 28-year-old female with a near normal BMI and anemia secondary to menstrual bleeding from a recent medical abortion, presenting with signs of intracranial hypertension as evidenced by the papilledema findings on imaging, as well as an elevated opening pressure on lumbar puncture. So how should we treat her? So, with all this knowledge in mind, treatment of the anemia is of utmost importance. So we got neurology, hematology, and obviously our service involved. And hematology recommended the intravenous iron followed by oral iron. And neurology and us, we recommended Diamox, just given the fact that her disc edema was quite severe. At her 1 week follow-up, you can see, her vision was initially 20/40 and 20/20, but now it's 2200 and 20/70. You might think to yourself, without an OCT, you might think, oh no, the IIH is, the optic nerve must be getting worse and worse. But if you get an OCT macula, you can see that the mechanism of her loss of vision is actually not from worsening optic nerve dysfunction. It's actually due to worsening subretinal fluid, which again shows the importance of conducting an OCT in this patient population. At her 2-month follow-up, you can see that her the only main sequelae of this episode was some optic nerve pallor, as well as some residual horizontal retinal folds or choroidal folds actually here, just adjacent to the right optic nerve. And this is the OCT. You can see that, there is the resolution of subretinal fluids and some mild disruption in the outer retinal layers as well. So, the 5 main take-home points that I want you to get from this case, as well as from this presentation, is the following. So take-home point number 1 is that a number of cases in the literature suggests a direct relationship between anemia and IIH. So this is something that you should be aware of, particularly given that we do see quite a number of these patients in the emergency clinic as residents and as staff. Take-home point number 2 is that a CBC should be ordered in all cases of idiopathic intracranial hypertension. It's a very cheap test to order. It has a quick turnaround, and it's particularly useful in cases where the presentation is very atypical, or if treatment does not respond with Diamox. And take-home point number 3 is that in IIH cases with coexisting anemia, there is a growing body of literature showing that treating the anemia has been shown to improve the IIH, okay? Take-home point number 4 is that, something that I wasn't aware of prior to being asked to present this case is that retinal manifestations do exist from, idiopathic intracranial hypertension. So it's important to be aware of this. And lastly, take home point number 5 is that an OCT macula is a great test to order for patients with acute papilledema, because again, it can help you distinguish the optic nerve dysfunction from, a CNVM or a subretinal fluid, causing paracentral visual field defects. So that's my presentation. I'm happy to answer any questions.
So, Jason, there was a question from the chat about the subretinal fluid in the fovea. So here you managed it by treating the anemia and the patient improved, but is there not a risk that if the fluid doesn't go away quickly enough, there could be some permanent visual deficits?
Yeah.
What's the time frame there, and what would you do if it was not responding quickly enough?
So that's a good question. So the mechanism of this, the subretinal fluid in this case is, again, the contiguous spread from the swollen optic nerve. So by treating the IIH itself, the subretinal fluid should resorb. So it's different from, it's different in terms of the mechanism from entities like CSR. For sure, if the subretinal fluid persists, there could be an accumulation of waste products and around the ellipsoid zone, which you can also sort of see in chronic CSR. So there is, somewhat of an urgency for treatment, but I think in terms of the treatment window, it's not as, it should be about the same as in cases of CSR as well, because the mechanism is in terms of the permanent visual sequelae from CSR is actually quite similar to the subretinal fluid in our case. So I'm not really too sure exactly what you would do if the subretinal fluid doesn't resorb.
So Jason, I think so the subretinal fluid or the subfoveal fluid just explains the visual field defect. That is not urgent to treat. So what's urgent is optic nerve dysfunction or optic neuropathy. So the visual field defects that typically happen with that are you get your enlarged blind spot, then your nasal step, and then your arcuate defects. So that, if you're starting to get arcuate, heading towards a surgical intervention. But for subretinal fluid, we basically just, we treat the raised ICP, and typically that resolves. And we haven't really seen any permanent deficits from subretinal fluid in this context. Okay, maybe just in the interest of time, we're going to move on to the next case since we have a couple more to present. Jason, do you want to share your screen? Okay, so while we're on the theme of IH, I'm going to present another one here. We're supposed to have a resident do this, but due to some late minute issues, I'm going to just present this. So this is another case we're going to see. I gave it the title, Look What I Found, and you'll see how that's relevant in a few minutes. So this is a 28-year-old woman who's referred for bilateral vision loss. She is obese with a BMI of over 42. She is a smoker, and she takes oral contraceptive pills. And she presented with pulsatile tinnitus and headaches for 6 weeks, and then blurred vision for about 4 of those weeks. So she presented to the emergency room. She was referred to ophthalmology, and we got a visual acuity of 20/80 in the right eye and 2200 on the left eye without a relative afferent pupillary defect. And here are her fundus photos. So you'll see that there is quite significant optic disc edema with a lot of cotton wool spots, hemorrhages, and there's also a few hemorrhages elsewhere in the retina. And I think this is due to what Jason mentioned before, is you can get a venous stasis retinopathy or a central retinal vein occlusion due to the high pressure at the optic nerve head. So I think that's why we're getting some of these hemorrhages here. So like Jason said, I think an OCT of the macula is very valuable in these acute severe cases, because this will explain some of that reduced central acuity. You can see how she had subfoveal fluid here. So we ran into a little bit of a technical difficulty because in the St. Mike's Eye Clinic, the visual field was performed, but we could not see the results. So we could not see the actual printout for the machine. So we had neurology help us, and the patient went on to get an MRI MRV that we see a partially empty cella here, a distal transverse sinus stenosis, all signs of raised intracranial pressure. And her opening pressure was very high, greater than 55 centimeters of water with normal CSF contents. So we're kind of stuck here because visual field is a very important test to let us know how we should proceed at this point in time. And so since she just had the LP, we got some temporary protection for her optic nerves. We started her on a higher dose of Diamox, and we brought her back in a few days to repeat the visual field. So we finally got the visual field from our first attempt, and you can see here it is very, very severely depressed. So right eye just has severe generalized depression. We have a constricted visual field with only a small island of vision left in the left eye. And in our repeat field, we got another similar result, indicating that this is actually a true deficit. And you can see our mean deviation is in the 20s. So this is very, very severe vision loss. So I think in this case, we have a young woman in her 20s who has essentially legally blind at this point in time. So I don't think medical treatment is going to be adequate for her. So what we decided to do was refer her to neurosurgery for a CSF shunt procedure. So it's routine for neurosurgery to do a pre-op CT before doing a shunt because they do use kind of image-guided technology on where to place the shunt. Now, she was admitted on a Friday night, and on Saturday morning, when they did the pre-op CT, they found this hyperdensity in the posterior aspect of her superior sagittal sinus, indicating a new venous sinus thrombosis. So this posed two questions here that are important to answer. So why is there a new venous thrombosis, and how should we manage this? So we'll talk about the why is there a new DVST a little bit later. But this was a very difficult question to answer, is how do we proceed? So this is a patient in her 20s with severe vision loss from IIH because she had a normal MRV, MRI, a very high LP opening pressure, who now has a clot on the pre-op CT. So Amandeep, are you able to launch the poll? So there's a few options here. One is you can just go for the shunt and anticoagulate after. The second is you can cancel the VP shunt and just do anticoagulation and Diamox. Another option is you could do a lumbar drain with anticoagulation, or you could just consult hematology and do a hypercoagulable workup. So there's no definite right answer to this, and there's multiple approaches that you could take, but maybe if you have an idea, what do you think is a good idea on how to proceed? I don't know if there's any other neuro-ophthalmologists too, we can online can get their opinion on this too.
So Jonathan, I'm going to end the poll here. You've got the audience baffled. A very nice split.
Okay, so hematology consult and hypercoagulable workup win. Okay, so in this case, there's risks and benefits to each here. So what we decided to do was actually just go for the shunt, because if we cancel the VP shunt and anticoagulate with Diamox, it's going to take at least a week or two for this clot to resorb, and Diamox is not going to give us enough lowering effect to help her vision. You could go with a lumbar drain with anticoagulation. However, the lumbar drain would have to be in for probably at least a week. And when you have anticoagulation on board, there can be some issues with this. And just personal experience, have not had good experiences with lumbar drains and neurosurgery. Hematology certainly should be consulted on this, but I think they're not going to provide timely advice, and we have to really move quickly to get her ICP down. So we discussed this with the patient. We actually decided to go for the shunt. We do this in some patients who have papilledema from DVST, and now is actually an optimal time since she doesn't have any anticoagulation on board. And neurosurgery is okay to do this. However, the risk of this is that we do have to wait 24 to 48 hours after the shunt to restart the anticoagulation, and there's a risk of propagation of the thrombosis. So neurosurgery was very helpful in this case, and we went for the shunt. So Saturday, she got her VP shunt inserted. However, we had to wait 48 hours after the shunt to start anticoagulation. And you can see here's our pre-op MRV. This was reviewed with the best neuroradiologies at St. Mike's, and there was clearly no thrombosis before. One day after the VP shunt, you can see that there's this thrombosis in the superior sagittal sinus. And then 2 days after we started anticoagulation and 4 days later, you can see that the thrombosis is propagating and it is starting to show up now in the straight sinus. So fortunately, the patient made it through and we did not have any complications. So the patient's papilledema resolved fairly quickly and her central acuity returned very nicely. And you can see these were her 2-month visual fields, and you can see how the center cleared up very well. And now she was very happy and she has very useful central vision. And we just saw her a few days ago and this visual field defect has improved better. And you can see on the repeat CTV now, her venous, her superior sagittal sinus is nicely recanalized. So we got her through it and she made it through. But the question is, why did this patient with IIH get a new thrombosis? It was clearly not there before. And the reason seems to be is that when you get a rapid reduction in your CSF pressure, what happens is your venous compartment, for example, your dural venous sinuses, they dilate, and what you get is venous stasis. And in our case, our patient was a smoker who was on oral contraception, and so this may have predisposed to this venous thrombosis. She did have a very extensive hypercoagulable workup by hematology, and it all came back negative. So this is not the first time this has happened. There have been 4 previous cases in the literature where patients with IIH have had an ICP lowering procedure and have had a subsequent dural venous sinus thrombosis. So this was a case in the Journal of Neuro-Ophthalmology where a 32-year-old woman got DVST after a lumbar drain. Now she had a very, very severe outcome and a very suboptimal one. And you can see here's the optic disc edema. On the pre-op MRV, you can see that the sinus is patent. This one is hypoplastic, but there's no dural venous sinus thrombosis. However, after neurosurgery placed a lumbar drain, the next morning the patient was lethargic, and you can see that there's extensive CVST, and unfortunately there was a subarachnoid hemorrhage and cerebral edema. So it's not just in IIH that these issues are seen. You can also see it after diagnostic LPs for other reasons, other types of therapeutic LPs, or even in the obstetrics literature. If you have an epidural, there have been 27 cases in the literature where a patient got a subsequent dural venous sinus thrombosis, usually presenting with lethargy, severe headache, or focal neurological symptoms. So the bottom line from this case is DVST is a rare complication of ICP lowering procedures. And we have to keep this in mind. So if a patient who has been previously diagnosed with IIH returns with worsening symptoms or worsening papilledema, especially if it's after an LP, we need to consider DVST in the differential diagnosis. Now, this patient was very fortunate because if we didn't send her for the shunt, this would never, probably she would have presented with a venous stroke or intracranial hemorrhage. Or if we sent her, for example, for an optic nerve sheath fenestration, no one would have ever known this was happening. So it was fortunate that we sent her for the shunt and neurosurgery did this pre-op CT. Otherwise, we would have never known that she had this dural venous sinus thrombosis. So that's the end of this case. Does anyone have any questions?
So John, can you just elaborate? There was a question from the audience on optic nerve sheath fenestration and then anticoagulation. Can you just elaborate on your answer there? Why that's not a choice?
So optic nerve sheath fenestration certainly an option in this case. I guess the problem here is one is she had significant neurological symptoms, headache, pulsatile tinnitus were very severe in her. So optic nerve sheath fenestration would not address that. Probably the bigger issue is that this was Friday night. At some places they would be able to get the optic nerve sheath fenestration urgently, but it's may not be available urgently. So neurosurgery did this the next day, and time was optic nerve in this case. But certainly an optic nerve sheath fenestration would have also been appropriate. But the ability to get that urgently was really the issue, and it would also require 2 surgeries. Now, if we did do an optic nerve sheath fenestration in this case, the patient would have had an unrecognized dural venous sinus thrombosis and probably would have presented to the emerge in a week or 2 with a venous stroke or intracranial hemorrhage. So it was kind of fortunate that we did this. So you can, so if you anticoagulate primarily, the anticoagulation does not lyse the clot. All it does is it prevents propagation and your body resorbs the clot. So if you just anticoagulate, you're not going to get sufficient ICP reduction in a timely manner, and she's going to permanently lose vision from it. So that's why you can't just anticoagulate this patient. You could add Diamox that likely won't have enough of an effect. This is a surgical case with this type of visual field. Okay, any other questions for this case? So since we have a little bit of time left, I just have a few clinical vignettes to show. Okay, so these are just a few short cases since we have about 20 minutes left. So these are just from my experience working as a neuro-ophthalmologist over the past 2 years, and just kind of asking what is the role of neuro-ophthalmology in the ophthalmology community, and when really should we be called? So, you know, ophthalmologists are very busy practitioners. So we have high volume clinics, but you know, maybe once or several times a week, you may have a patient that comes in where you think there's a neurological or neuro-ophtho problem. So there's two options for the ophthalmologist in this case here. So you could consult us, and that's certainly reasonable. However, you know, every MD has the ability to order an MRI as well. So there's basically two routes that most practitioners will take here. Now, if you order an MRI, there is one possible outcome is that you order the MRI and the MRI is reported normal. And so this is where most of our referrals come from, where there's, you know, suspicion of a neuro-opt problem. The MRI is normal. So this is, you know, the main type of patients we see. And there's a few options, it's a few things that may have happened. One is that the wrong MRI was ordered. So maybe it's you know, a brain issue, but orbits were ordered, or it's a venous issue and an MRI was ordered. There might actually be no lesion, so it's possible that this was read correctly, or it's possible that there was a lesion on the MRI that was missed. So this is really what we spend most of our time figuring out. However, if a lesion is found, what I tend to see is that the ophthalmologist will refer the patient directly to neurosurgery, radiation oncology, or depending on the case, neurology, and this may be appropriate in certain circumstances. However, I'm just going to show you a few cases here that, you know, when a lesion is found, you have to kind of step back and ask yourself a few questions. Is the lesion actually significant? So is it related to the presentation, or is it an incidental finding? Sometimes these lesions that are found actually don't require treatment. So is it relevant and does it require treatment? Now, if it does require treatment, we have to ask the question, who should provide it? So should it be a surgeon or radiation oncologist? And if treatment is needed, how quickly does the patient need the treatment? So I'm going to argue here with a few cases that neuro-ophthalmology really should be the gatekeeper into these specialties. And, you know, neurosurgeons, at least the good ones, understand that they really need to work closely with neuro-ophthalmology, and they can't simply treat the scan because you do get into trouble here. So I'm going to show you a few cases here to kind of demonstrate this point. So here's a 73-year-old man who presents with new left ptosis. So he has a history of hypertension, diabetes, and he presents to the emergency room with a 5-day history of a left droopy eyelid, diplopia, and pain around his left eye. So the ophthalmologist sees him and diagnoses a left third nerve palsy. So we all know in anyone with a third nerve palsy, you should get a CTA or an MRA urgently to rule out a posterior communicating artery aneurysm. And that's exactly what the ophthalmologist did. There is no posterior communicating artery aneurysm. However, on the scan, there is a left planum sphenoidal meningioma that involves the left cavernous sinus. So we do know that a third nerve palsy can be the only manifestation of a cavernous sinus lesion. And so this seems like it could be related to the third nerve palsy. So the patient is referred to neurosurgery. And so neurosurgery sees the patient and schedules the patient for a tumor board meeting to decide surgery versus radiation. However, fortunately, this patient went to his optometrist too, and the optometrist sent us a referral. So here we see the patient. So you can see that he has complete leftosis. He has complete limitation of elevation, adduction, and depression with full abduction. And if you look carefully here, his pupils are equal sizes. And so I'm going to show you up a closer photo here. You can see pupils are both equally reactive to light and equal size. So we actually got a better MRI. This is an MRI dedicated to the sella. And here you can see the lesion here. It's this kind of grayish lesion, and it is in the cavernous sinus, and it is exactly where the third cranial nerve is. So the third cranial nerve is with 4-6 V1, V2 in the cavernous sinus. Now, and this could potentially explain his symptom. So M&D, can you launch this poll here? So what do you think is the best option for this patient? Should he have a neurosurgical resection of the tumor? Is radiation a better option? Should he go with dexamethasone, which is steroid to reduce any potential edema, or should there be no treatment?
We've got a pretty good split again here.
Okay, so do you want to show the results? Okay, so dexamethasone is actually leading, but yes, exactly, pretty good split. Okay, so this is really interesting case because the lesion is in the exact location to explain it. However, the lesion cannot explain his presentation. So there's a few reasons. One, he has a complete pupil sparing third nerve palsy. So the rule of the pupil, it's called, says that when a lesion compresses the third cranial nerve, the iris sphincter should be impaired. So if you remember the anatomy of the third cranial nerve, the parasympathetics are on the outside of the nerve. So if this meningioma is pushing the nerve, we should have a dilated and non-reactive pupil, like this patient has here. He also had a very acute onset of his symptoms. So they came on with within a day or two. And we know that meningiomas are very, very slow growing lesions. So in this case, we made a diagnosis of microvascular ischemic third nerve palsy due to his diabetes with an incidental finding of a left cavernous sinus meningioma. We canceled his neurosurgery and radiation oncology appointments, and we observed him. And you can see here he comes back 3 months later, and he is back to normal. Okay, so the question is, does this meningioma need treatment? And that's a question that we need to decide with the patient. So radiation could be an option here. However, radiation does have risks, and this patient likely had this meningioma for years. So we decided with the patient, we're going to repeat the MRI and see if there's any interval growth, and then we can decide whether he needs radiation or not. So here's the flip side of this case. So this is a 54-year-old woman with new leftosis, again, has a history of diabetes and hypertension, who has 2 days of leftosis. So she goes to the emergency room again. Again, the ophthalmologist makes an appropriate diagnosis of a left third nerve palsy. And again, we know every third nerve palsy should have a CTA or MRA of the head to rule out a posterior communicating artery aneurysm. And so the CTA head was performed urgently, and you can see the impression here is no abnormality. So the patient fortunately came to us, and you can see that there is again left complete ptosis, complete limitation of elevation, adduction, depression with full abduction. However, this patient's pupil is different. Her pupil is dilated and completely non-responsive to light. So there's a few options here, right? You have a patient who's diabetic with a normal CTA, you might be tempted to just observe this patient. However, it does not make sense here, okay? Because the patient has a complete third nerve palsy with a dilated non-reactive pupil with an acute onset of symptoms. This clinical presentation is highly suspicious for a PCOM aneurysm, and that's exactly what we found. There's a 7 by 5 millimeter left PCOM aneurysm that you can see here. It took our neuroradiologist 5 seconds to find this, whereas the radiologist at the other hospital completely missed it. And you can see it right here. again on the scan. So luckily we can see she had an urgent cerebral angiogram. You can see the boot-shaped aneurysm here, and it was nicely coiled. And at their follow-up, her symptoms started to improve. Okay, so the lesson here is, if you rely solely on your radiologist and your other specialties, you may run into trouble. So what I'm arguing for here is if you have a patient with a neuro-ophthalmic presentation, especially if it's not making sense, we would like to see these patients and we can definitely help. So 2 more short cases here. So this is a 53-year-old woman who describes worsening vision in her left eye for about 6 months with some on and off pain in her eye. So the ophthalmologist noticed that the left optic nerve looks pale, and the patient was referred for an MRI to rule out a compressive lesion along the optic pathway. And so the radiologist here says that there's increased T2 signal of the left optic nerve without abnormal enhancement. It is non-specific, but it raises the concern for a possible mild non-enhancing left optic neuritis, and they recommend urology, probably neurology consultation, MRI of the spine, MS protocol to assess for spinal cord lesions. So luckily the patient did come and see us, and as you can see, her central visual acuity was normal. It was 20/20 in both eyes. Her color vision was normal, and you can see that you have a left superior arcuate defect. And here's the fundus photographs. And you can see here that it's actually not pallor of the nerve. It's actually that there is no nerve down below. So this is a knot or a complete inferior cup. There's actually no neuroretinal rim. And at the top, you can see that there is some nerve left and it's of normal color. So the diagnosis here is actually left glaucoma, and actually no further interventions are needed. So the point I'm trying to raise here is if you order an MRI directly and you rely on your radiologist, this patient's gonna end up in the multiple sclerosis clinic and is gonna have an MRI of the spine and potentially other invasive testing. And anyone knows if you go to the MS clinic, you usually don't leave the MS clinic. So MS is diagnosed based on dissemination in time and space. So when you get into the MS clinic, you keep getting MRIs every 6 months to look for new lesions. And you can see how with a proper diagnosis here, we can save the patient a lot of time from unnecessary appointments, and we can also save the healthcare system a lot of resources. So if we look back at the MRI, it was actually, there really was no high T2 signal, and it was actually just a small optic nerve that was atrophied, so it was misread. And so the last case I want to show here is here's a 44-year-old woman who has 3 months of progressive blurred vision and was found to have papilledema. And you can see that there is this very large extraaxial mass with edema adjacent to it with midline shift. This was thought to be most consistent with a meningioma. And so the patient was referred directly to neurosurgery, and surgery was scheduled in approximately 3 to 4 months. Fortunately, the patient actually ended up coming to see us. And if you look at her optic nerves here, you'll see that there does look to be some swelling, but the nerve also looks to be very pale. So to me, this looks like a chronic papilledema that's very atrophic, and just trying to predict her visual fields, I anticipate that the visual fields will be pretty bad. And that's exactly what we found. In fact, her visual acuity was counting fingers in the right eye. It was 20/40 in the left eye, but there was only a small island of central vision. So the point I'm trying to make with this case is that you can refer the patient directly to neurosurgery, but neurosurgery is going to have a hard time putting this into context. And even though we may not change the diagnosis here, we can change the urgency that surgery is given. And so in this case, we discussed this with the neurosurgeon, and in fact, instead of being 3 to 4 months, this patient needs surgery in 3 to 4 days. And so we started her on dexamethasone, Diamox, and we saw her back yesterday actually, and she did get a little bit of vision back, and the papilledema had resolved. So that's the end of my presentation there. So the main point I want to make here is that we do get a lot of referrals when the lesion is not found. However, if you do find a lesion, still consider referring these patients to us, because I think we can still play an important role, whether that's in making the correct diagnosis, or even if the correct diagnosis was made, helping in determining the timing of an intervention. Thank you. Does anyone have any questions or comments?
Thank you, Jonathan. That was fantastic. There was a quick question from the audience about the case where the PCOM aneurysm was missed. There was a CTA ordered that was appropriate. Was it just missed or not seen on that study?
It was on the image itself, but the radiologist missed it. So there's there has been studies on this, and the two issues are, one is the indication for the CTA that was written to the neuroradiologist or the radiologist may not be correct. So if you write headache, diplopia, droopy eyelid, dizziness, then the radiologist doesn't know where to look, and that's one reason why these lesions are missed. So that was not the case here. In fact, the emergency room doctor clearly wrote left third nerve palsy, rule out aneurysm. And so the indication was correct. It was on the image itself, but the radiologist missed it. And that is a life altering miss, because we know that when aneurysms cause new neurological symptoms, that means that their morphology is changing. And these are very high risk for rupture and subarachnoid hemorrhage, which has extremely high morbidity and mortality. So, that is a devastating misread on the MRI. And luckily, the ophthalmologist knew something was not quite right and then referred the patient on to us.
Ed, I think you're muted. I can see you talk. I can't hear you. There you go.
I want to say the old presentations were excellent. The first one about the anemia, very excellent, interesting point. We have seen a couple of patients with severe anemia or very atypical presentation. We had a very hesitant to attribute to the anemia because of that, because of poor literature on the topic. So hopefully you'll help us figure that out. I wonder how many patients that we actually do end up getting LP and end up getting a small dural sinus thrombosis that is never picked up and then either subsequently resolves or vision or the papilledema gets a little worse and we think that the disease is actually worsening. So very nice point there. And really excellent 3 cases at the end that I really enjoyed listening to that and I really like the approach to the fact that we don't see the patients that the lesion is actually found on. And of course, we've all had similar experiences, excellent cases.
Yeah, and really, for neuro-ophthalmology, we really have to work closely with neurosurgery and radiation oncology. And I think that does happen at some places, but some places the neurosurgeons and the radiation oncologists will get into a habit of simply treating the scan. And there are many things that can go wrong in a patient that has a normal MRI. And even if the tumor looks like it's shrinking, there can still be many things that are going wrong. For example, radiation-induced optic neuropathy, infections, intracranial hypertension, they're not always seen on scan. So I think we still have to make some progress with our neurosurgery colleagues, and so they understand the value of working with ophthalmology and neuro-ophthalmology.
Exactly, and particularly the common thing is when, as you know that, all of that, that neurosurgery orders visual fields are normal, the treatment is postponed, but the patient actually has optic neuropathy, and the treatment has been delayed because of inappropriate evaluation of the data. So
exactly. So there are some hospitals in Toronto, teaching hospitals, where neurosurgery orders their own visual fields and interprets their own visual fields. And we all know as ophthalmologists, maybe a quarter to 50% of the visual fields we get are unreliable, and they have to be interpreted in the context of a good clinical exam. And that means looking at the retina, looking at the optic nerve, and we have OCT. And so I'm a little confused on how, even as ophthalmologists, we have difficulty in these visual fields, how neurosurgeons feel that they are able to do this. And there are guidelines for neurosurgeons that they should get a pre-op ophthalmology consultation for many of these tumors, but unfortunately it still does not happen.
Yes, and a frequent just that you've spoke about before as well, as the patient's pituitary tumor with normal fields, but binasal thinning on the ganglion cell analysis, which is of course never done, and they're just sitting in there waiting to get the visual field defect, which when they should be getting treatment.
Exactly.
I will put a plug in to say that sometimes there's there's a fear that getting an appointment with a subspecialist like a neuro-ophthalmologist can be difficult, but we're pretty fortunate in our department to have very fast access to some excellent neuro-ophthalmologists like Dr. Margola and Dr. Michelli. So if anyone's worried about getting patients in, I will say that these guys are very good at getting patients in quickly.
Right, so we will see, you know how to contact us, phone, email. We will see the patient the same day, the next day, within a short period of time. So, you know, access to neuro-ophthalmology is not an issue in Toronto.
Yes, I want to thank you very, very much for these presentations, Jonathan. It really was fabulous, and also give you some pause when you see all these issues with things being missed, scans being misread. I really agree that involving neuro-ophthalmology is clearly critical for for saving vision in some of these patients. So thank you very, very much again for these fantastic rounds. Speaking of visual fields, we have a long-awaited glaucoma rounds coming up next week. So Dr. Schlenker will be presenting on glaucoma. We haven't had glaucoma rounds in a while, so looking forward to that as well. So have a happy Halloween, everyone. Safe, happy Halloween. Hope you get lots of candy, and we'll see you next week.
Great job, guys.